Good morning to everyone from Binghamton and good evening to everyone from Vellore. Today we are having our second talk on the seminar series with a collaboration with the School of Healthcare Science and Engineering at Vellore Institute of Technology and the School of System Science and Industrial Engineering. Today we have a faculty from Shine, Dr. Kishor Narayanan, who is an associate professor at Shine at Vellore Institute of Technology. His research lies at the intersection of neuroscience, rehabilitation engineering, and biosignal processing, with notable work in EEG, EMG acquisition, brain-computer interface development, motor imagery, and robotic rehabilitation for neurologically impaired patients. Dr. Lakshmi Narayanan earned part of his graduate training in the US, including at the University of Wisconsin-Milwaukee. He has been involved in developing novel medical devices, VR-based sensory motor activation systems, and rehabilitation prototypes for upper limb recovery in stroke and other motor impairment contexts. Dr. Kishore, we are very happy to host you here. Please, the floor is all yours. Thank you.
Thank you. Thank you for that wonderful introduction, Dr. Srinath. So I'll go ahead and share my presentation. If I can figure out how to do that. Hopefully my presentation is visible.
It's visible, yes.
Okay, I'm gonna get this out of the way.
Yes, it's visible now.
All right, perfect. All right. Good morning, everyone at Binghamton, and evening to my fellow colleagues here. So today's topic is going to be about brain-computer interfaces. What is brain-computer interface? What are the different types? And how do we use that in various healthcare applications? I realize that I'm speaking to a general audience, not people who are necessarily experts in brain-computer interface. So this talk will be a little bit on the surface level of BCI. And I also have a short demonstration planned here. Hopefully, if things go well, then we'll have that demonstration as well after I'm done presenting. So with that said, so brain-computer interface, as the name implies, is the interface between the human brain and any computer. A computer doesn't mean just compute the normal PCs that you see, but anything that can, a hardware that can compute the signals that are received from the brain and turn that into certain type of control. So any device that lets the human brain communicate with and control external software or hardware, like a computer, is called brain-computer interface. Now, to capture your brain signals, you have multiple modalities. There is EEG, which is electroencephalography. That's basically electrical recordings from the brain. In that, there are also various types, which we'll see in a bit. There is also FNIRS, functional near-infrared spectroscopy, which records the blood activity in the brain. Then there are MEG, magnetoencephalography. Then you have even muscles. You can take electrical activity from the muscles through EMG and use that as part of your BCI as well. The brain part in brain-computer interface doesn't necessarily mean that the signals have to come from the brain directly. It can be through any signal that you can derive from the human body that you can use to control something. But for the sake of today's topic, we'll only focus on the brain part. So these commands that we derive from the brain can be used to control computers, robots, prosthetics, or you can control your virtual self inside a VR environment as well. So the types of BCI based on its invasiveness are three. So you have the invasive one, which of course, people who are familiar with Elon Musk's Neuralink might be familiar with. That's That's when you actually undergo a surgery and you have small microelectrode arrays implanted in the cortex of your brain. So this gives you the cleanest signal possible, and you can use that for control of a prosthetic arm, a robotic arm, or if patients have complete paralysis, help them uh, control their limbs. But of course, the downside is this requires surgery, and that's highly risky. The next one is partially invasive. Um, so they still require surgery, but it doesn't require opening up the skull. So you can just have it placed underneath the skin, or in sometimes just over the brain, not inserted into the brain. They carry less risk than the invasive ones, and they definitely have better signal to noise ratio than your normal EEG. And this can be used for seizure mapping, or if someone has locked in syndrome, aphasia, they are not able to communicate anymore. Then you can use this for a speller control. I'll get to how you can use brain-computer interface for speller control in a bit. And then the last type is the one that I discussed in the previous slide: EEG, FNIRS, MEG. All these are non-invasive surface level EEG. You just wear them. These comes in caps or individual electrodes. You just place them on top of your head. It's totally not invasive. It's super safe. But the problem is you lose good signal to noise ratio, because the electrodes on top of your head has to get the brain signals after it has passed through your skull, your skin, and all the hair and everything in between. So of course, there's going to be a loss of signal, and this also suffers from poor spatial resolution, meaning you get these signals, but it's hard to pinpoint which part of the brain is actually producing those signals. You have to get creative with a little bit of mathematics and do some sort of source localization to do that. But even then, it's not going to be as accurate as having a microelectrode inserted into the cortex. But yeah, the upside is it's totally easy to set up. You don't need surgery. Anyone can set it up here. In fact, we have it set it up here. So and it's quick, it's easy, and it's cheap, and it's also safe. Uh, Moving on to the next classification of BCI, the types of BCI based on the interaction paradigms. So depending on how the interaction is, you have three types. You have active BCI, where the user intentionally modulates their brain activity, meaning that let's say I have EEG hooked up to a patient, and we ask them to, and let's say this patient is paralyzed. We have something like an orthotic, a robot arm, an external robot arm or an orthotic fitted to their hand, and we ask them to imagine just closing and opening their hands. And these signals from the brain can be picked up using EEG, and that signal, that commands can be sent to the robot or the orthotic, and they can perform that movement. This is called active BCI, where you have the user intentionally modulate their brain signal, intentionally perform a certain mental exercise. Then there's reactive PCI. This is where you give the user a certain sort of stimuli, and the brain responds to that, and you're able to check what stimuli are they focusing on, and based on that, you can use that as a command for, or a way to control certain spellers. So so a good way to explain this is through SSVP. SSVP stands for Steady State Visual Evoked Potential. Uh, the name might sound complicated, but the concept is actually very simple. If you have three different squares, white squares on a black background in your computer monitor, and each of those squares are are flickering at a certain frequency, then if a user just focuses on just one of the flickering boxes, based on the EEG from their occipital lobe, the lobe that gets the signals from your eyes, uh, based on the signals that you get from there, you will be able to tell whether which target they are actually focusing on. And based on that, you can create spellers and more. I'll get into more detail when we get into SSVP, but that's basically the idea for reactive BCI. And then finally, you have passive BCI. This is when you don't ask the patient or the subject to actually perform any brain activity or mental activity, or you don't give them any sort of stimuli. They're just let to be as they are, and without any explicit, they can just stay in their normal mental state without explicit intent. And the EEG just monitors their brain activity and uses that to understand how the patient thinks and how their brain reacts to different things, and uses that to adapt. Let's say if they have a rehabilitation uh, regime where they have to actively where let's say you have a robot or a physiotherapist moving their hand. Let's say you're doing upper limb therapy and for a stroke patient, and you have the physiotherapist or a robot moving their upper limb, and you can have a passive BCI control to see how the brain reacts to someone moving their hand all the way. And based on that, you can adjust the difficulty level or the number of trials, the number of times they do the exercise, and so on and so forth. So this is more of a monitoring thing. There is no active control here, but they still come under the BCI umbrella. So I talked about active BCI and reactive BCI. And within active BCI, I kept saying that you just imagine a certain movement, or you have a certain stimuli given to you in reactive, but and the EEG just picks up those signals. But what exactly happens in the brain, and what type of signals does the EEG actually pick up? So the first one is event related potential. This is basically spikes that you see in EEG when a certain stimuli is given to a certain to a patient wearing EEG. So event-related potentials, or ERPs, are brainwave patterns that are time locked to an external stimuli or event. So let's say the flickering targets I was talking about, or an auditory signal, or even them performing a motor task. These are measured using EEG, and they reflect the brain's electrical response to that specific activity. So EEG, normally you can collect it anywhere from, say, 128 samples per second all the way to 20,000 samples per second. The more sampling frequency you have, the more accurate your time locking event-related potential is going to be. So what happens is, there are two major components to it. There's a positive peak and a negative peak. So as soon as the stimuli happens, there's going to be a spike followed by a dip, and then the EEG comes back to normal. So this, based on how long it takes from the actual event to when the stimuli occurs, they are classified as P300, N200, or N400. The 300, 200, and 400 here just means how many microseconds after the stimuli this particular peaks happened. And the P and N stands for the positive and the negative peak. So yeah, based on this, these are telltale signs that the subject or the patient has undergone a certain stimuli, and the brain is responding to that. So these are short ways of getting the brain's activity and use that as part of BCI. But the more interesting part is the event-related synchronization and desynchronization. This is actually the bread and butter of my lab here, where we do BCI constantly on various types of paradigms. So this is very interesting. The previous signal that we saw, event-related potentials, are basically you take the electrical activity from the brain. So you get the signals as um, um, microvolts versus time. So it's in the time domain. But when you convert that into the frequency domain, you get even more information about the brain's activity. So the brain activity based on frequency bands are divided into alpha, beta, gamma, theta. So you have all these different frequency bands, and each band, so alpha or mu, for example, it's between 8 to 13 hertz. Beta is 13 to 30 hertz. For BCI, we mostly focus on the mu and beta bands because that's where most of the motor related activities show up as. So what is event-related desynchronization, resynchronization, ERD, ERS? So ERD is when, let's say, a certain person performs a motor activity or even imagines performing a motor activity. What's going to happen is the in the premotor and primary motor cortices, there's going to be a reduction in the synchronous oscillatory activity. There's going to be a reduction in the activity, which will show up as a drop in the overall power. And that you can see in the graph here, that is called ERD. And then the rebound after that is called the event-related resynchronization, or ERS. So what this gives us, as you can see, you have the baseline signal, and then when the patient imagines a certain action, let's say moving their hand or opening and closing their hand, whatever, it's going to show up here. And then right after they are done, it's going to rebound and return to baseline. This here is basically an on-off switch. So whenever you see ERD in your EEG signals, you're going to treat that as the on switch, and the rebound is the off switch. So I can map this control, ask the patient to just imagine opening and closing their hand, and map that into the motor that's inside my robot hand or orthotic or a prosthetic. I can just connect it to anything I want, or even a wheelchair. So they can move it forward or backward based on this. So you can use this as an on-off switch. And the other one, which I briefly discussed about, is the steady state visual evoked potential, SSVP. So this, like I said, has multiple targets that flicker at various frequencies, like 10 times, 10 hertz meaning 10 times a second, 15 hertz or 6 hertz or whatever. So when the user observes a particular target that is flickering at a known frequency, we know what frequency that target is flickering at. Then when you take the EEG from the occipital lobe, which is at the back of the brain, you're going to see oscillatory activity that's going to match the same frequency of the target that they are focusing on. So let's say in my screen, I have three different targets, one flickering at 6 hertz, the other at 10, the other at 15. If I focus only on the 6 hertz target, then the EEG activity from my occipital lobe is going to oscillate at 6 hertz. And that's how I know that that's how I know that the user is focusing only on that target. Now, how do we use this as a speller? I keep saying that this can be used as a speller. So imagine you have a grid of flickering targets, each at a different frequency, and each assigned a letter. So you have the letter A, B, C, D, all the alphabets, and each of them are flickering at a known frequency. So I can spell out my name by just focusing on each letter at a time. And based on the oscillatory activity from my occipital lobe, I will know that this is the letter I'm focusing, and you can use that to spell. Now, with the advent of LLMs, you don't necessarily have to just focus on each individual letter to spell out something. You can have general letters, and the LLM can form entire sentences based on a few cues that you give it, and it can also change the words that are shown on the flickering targets on the fly based on the context of the conversation that you want to have. So this is highly exciting technology. The only downside is the flickering targets. It's like white rectangles or squares in a black background, and that can get very uneasy for the eyes. So to somewhat mitigate this, we have something called a Gabor patch, which is basically small lines that flicker at certain frequencies, but they are more easier to watch, and the signals are as reliable as just watching a white target flicker in a black background. And then we move on to motor imagery. So when I said ERD, ERS, and when you imagine a movement, this is what I meant. Motor imagery. So I really like to do this experiment in class when I'm talking about motor imagery, and to just show my students how wonderful our brains are. So I'm going to try and do the same here. I'm going to quickly stop sharing my screen so that I can see the audience. So let's start with how many are right-handed here? Yeah, okay. So I can see a couple of hands go up. Okay, so okay, let's take your dominant hand, for example. It's fine if you're right-handed or left-handed. Let's just take your dominant hand. Now we are going to do a mental exercise. Everyone, I'm going to do it, and everyone is going to do it along with me. So imagine you're sitting on a chair, and there is a desk in front of you, and there is a white sheet of paper. There's a pen lying right next to it. You're going to go pick up that pen with your dominant hand, be it right or left. You're going to pick it up. No, you're not going to actually do the thing I'm saying. You're just imagining with me. So imagine picking up the pen. You can feel the weight of the pen. Now you're going to take that pen, press it down on the piece of paper, and you're going to write your name. Focus really hard on each and every letter of your name. Okay, that was easy, right? Everyone was able to imagine that. Okay, now stay with me. Now you're going to take that same pen and pass it on to your non-dominant hand. Okay, and now you're going to press it down on that piece of paper and try to write your name again. It's going to be slightly harder, right? But it's just imagining. You should be able to imagine it just fine. But since you didn't have that skill, you are not able to imagine it. So this is the basis kind of sort of for motor imagery. The inverse of this is also true. What you saw here was an example of the skill that you didn't have, you were not able to imagine. The flip side is, if you can imagine and keep practicing a skill just through imagination, you're going to obtain that skill. So meaning that your brain, we have EEG, and you're able to get electrical signals from it. When I perform a certain movement, like folding and opening my hand or moving my arms around, I'm going to get electrical signals from my EEG that shows that I'm performing a motor movement. Now, the brain is awesome because I can just stay still and imagine just moving my hand, or imagine opening and closing my hand, and the brain is still going to produce the same signal. It's not going to be as clear as actually performing the movement, but through practice, you can get that signal as good as actually performing the movement. Now, why is this useful? So let's say someone had a stroke or paralysis or spinal cord injury, whatever that, that has cut the connections that you have from the brain to your limbs. Your brain is plastic, meaning it's malleable. So you can through motor imagery, you can keep practicing motor imagery movements, and through that, you can form new connections, and through that, you help rehabilitate patients. Now, the parallel aspect of this is you can also use that as brain-computer interface. You can have someone imagine a certain movement, and you can pick up the signals from the brain using EEG, and you can use that to control uh, anything that you want. So that's motor imagery. So the key features of motor imagery is it gives you a mental representation. Individuals imagine performing a physical task. Uh, it is a cognitive rehearsal where the brain mimics the neural activation pattern of the actual movement, meaning that it pretty much shows the same type of, generates the same type of brain signals as in performing the actual movement. And also, there's no physical movement involved. So it's best for people who are paralyzed or can't move. So like I said, when you do motor imagery, there's going to be the ERD and ERS signals in your EEG, and that can be decoded to control external devices like robotic arms, exoskeleton. Parallelly, it can be also used in rehabilitation, where the patients form new brain connections through this practice. All right, I'm going to move on to the demonstration. Second. Okay. Okay, I have here with me Chandresh, who's a research scholar in my lab. Chandresh, wave hi, the crowd. Yeah. So what we have here is Chandresh is wearing an EEG cap. This is from a company called Open BCI. They are really good portable EEG, and they're quite cheap as well comparatively. So I have him hooked up to EEG, and what you see on the screen here are his EEG waveforms. Is it not visible? I think it's blown out. Yeah. Okay. Okay. There you go. So that's his EEG waveform. So EEG is very sensitive to motion artifacts. So Chandresh, can you blink your eyes for us? Keep blinking. So you're going to see oscillatory activity whenever he blinks his eyes. There you go. And even motion artifacts, like can you move your hand around? Yeah, that's going to create some huge spikes. So that shows how sensitive the EEG actually is. Okay, so with that, I'm going to show a demonstration here where Chandresh is going to use the power of his brain to control a digital avatar of himself. Chandresh, go ahead. Yeah. Wait. So what you see here is a digital avatar of Chandresh. We took his photo and modeled it in 3D. And before this talk, Chandresh trained the BCI system by imagining left hand and right hand movement. More specifically, he imagined beating a drum with your left hand or your right hand. So he trained the algorithm with this, and it has classified and it is ready to go. So now what Chandresh is going to do is show a demonstration where the system is going to tell him to imagine a certain hand and he's going to just imagine moving that, and the system is going to classify on the fly whether he's imagining the left hand or the right hand, and his virtual avatar is going to perform that movement. Now, go ahead. It's the baseline 20 seconds, 60 seconds. Okay, just stay still. So there is a baseline period for 60 seconds. So we'll, in the meantime, I'll, yep, okay, there you go. Pause in 60 seconds. So you can see the orange text that tells them which hand to actually imagine. And you can see a certain flickering going on. That's the algorithm trying to find in real time which hand he's actually actively imagining. So it's not 100% accurate. It's like it gets you close to 75 to 80%. So there might be some misclassifications, but the impressive part is he's actively controlling his avatar just using his brain in real time. So it says left, focus. There you go. There you go. Right. All right. All right. Thank you. Thank you so much, Sandesh. So that was the little demonstration I had. Okay, can you get me SSVP?
That was great.
Thank you. So since we have time, I'm going to try and show the keyboard. We're going to try and open up the one of the SSVB, the Gabor patch I was talking about. We are trying to set up that experiment as well. So yeah, once it's set up, I can show that too.
Doctor,
In the meantime,
Professor, I have a question.
Yes, I can field questions.
Yeah, while you're setting up, I think you're through the presentation, and this is based upon someone I know where is the status of brain implants for Parkinson's?
Oh,
I don't know
that
if
is
you're
being, yeah, that is
just
being
curious.
extensively
Again, this is a very
researched.
personal question for a colleague or somebody whom I've known for 40 years. And I know
That
at
has
least
been
2 people.
extensively researched on, sir. The top 3 neurological disorders that are being actively researched for BCI is stroke, spinal cord injury, and Parkinson's. And I know that you have a special interest in autism. So that is also one of the emerging fields where the same type of motor imagery is used for developing social interactions skills in children with autism. We here are trying to set up that kind of an experiment here. We are just going through the hoops to find the right population.
For autism or Parkinson's?
For autism,
Autism is a tough one, right? It's a spectrum disorder, and it's a very broad spectrum. Whereas not that Parkinson's is any easier, but it afflicts a different population, a different demographic.
That's true.
Right? And it's anyway, just curious, because I know that today people are using implants, and in some cases it seems to work, and so on. So I was just curious. Again, from a personal perspective, I know a couple of people who are plus or minus a few years from me, who are impacted by Parkinson's. That's why I asked.
So there are, I mean, there are multiple things, but broadly speaking, there are two major aspects that affect the effectiveness of the BCI. One is, of course, the hardware itself, meaning where you're getting the signal from, and is it invasive, non-invasive. The second is the human factor. How, let's say, motor imagery. Chandresh has been in the lab for more than a year, and he's been through all the experiments, so he's able to imagine it at, frankly speaking, it's at a very impressive level. Even I can't do it at that level. But if you have anyone hooked up to this for the first time, they're not going to have this kind of success at actually being able to imagine perfectly for the system to decode it on the fly.
And one request, I know I'll mention this to Dr. Geeta also next week when she's here. A week from today, I know Srinath knows this, and he's working on the schedule with Dr. Young. I think it's all done. Our provost is going to be on your campus on Monday, November 3rd. No. The previous Monday, April something. Sorry, October something. I'll just look at my calendar. I got the wrong Monday.
It's October 27th.
27th. It might be good for him to see what you're doing, right? The practical demonstrations of what Shine in general, because I know Shine is a group of very highly motivated, excellent, technically superb people. And I have suggested that he comes to Shine. I hope he does. And along with, say, Dr. Nirmala Grace and ARC with Dr. Tangaraja and others. So when it comes to Shine, I think if you have time to show the provost, our provost, and Dean Atul Kelkar is also going to be with him. And Atul is my successor, and he's very good too. And the vice provost Madhu is going to be with them also. And this does not matter, but I'm going to be on your campus November 6th and 7th. So Yogendra is thinking about, I know 2 days to take vacation on, November 6th and 7th.
Well, in that case, I can host you here, sir. We'll be happy to do that.
No, I'm just kidding. No, I'm just kidding. No, I'm just.
I know.
No. It's
Yeah,
always a pleasure
but
to meet with Dr. Geeta and her team, and all of you guys are just wonderful. Please go ahead. I know you had a demo set up.
yeah, I got a question here from Dheeraj. Would it be possible to model BCI data to make inferences on possible future health issues?
So very good.
Yes and no. Yes, meaning depends on what you're trying to look for here. So like I said, in BCI, for an effective BCI, there are two factors, the hardware itself and then the human factor. So any shortcomings you might see in, let's take motor imagery specifically, it depends on a person's skill. But something like SSVP, that should be common across different subjects, and any drop in performance in that, if the model shows consistent performance in other normal subjects, and if it shows a dip, that might be an indicator to some sort of a potential health issue. But I'm not super familiar with that field or that parallel field of BCI yet. Mine is more on helping with health issues, but this is actually interesting. Yeah, I'm gonna look more into it.
If it can, I don't know enough. I don't know anything, so not even enough about if it can be used to predict brain-related issues alone. For example, today, just to name one, glioblastoma is almost not a very good sign, right? And if that can be, or the presence of, again, what I'm saying may be completely wrong, the presence of brain aneurysms, right? Or aneurysms in the brain, all of those would be very nice to, I don't know if it can be done.
modalities like EEG, FNIRS, or fMRI, all those can be used to diagnose those kind of
But it's
disorders.
after the fact, right?
I
Like,
mean,
and I think
I'm
going
not an
back to what
expert
Dheeraj asked,
as well. Yeah,
prediction,
but
right?
Mhm.
For example, a very different example would be coronary artery calcium score can predict the formation of calcium in arteries and the potential for cardiac disease, right? Or things like that long before. So I think that's where Dheeraj might
Yeah,
be
the
thinking
ability to
about.
perform motor imagery or any brain-computer related, BCI related activity might be an indicator, but that will be interesting to see.
Something to think
Uh, I-
about.
yeah, yeah. I mean, underneath it is again a machine learning algorithm that's going on. So can the modality like EEG and the machine learning algorithm can of course be used for diagnosis as well, but at that point it's not BCI. So I'm just thinking how
No,
these
no,
two
correct,
can,
correct.
yeah.
Sorry, I kind of digressed. Please go ahead.
No problem. So we have SSVP. Again, this is just work in progress, so apologies for apologies if it doesn't work. But yeah. So what you see here are two blinking targets. So similar to how Chandresh was able to control either the left hand or the right hand, we are hoping, but that requires a lot of cognitive load. He has to actively imagine moving his left hand or his right hand. This one is SSVP using cardboard patches. It's not just white targets on a black screen. This is, I don't know, the camera doesn't do justice. It bloomed the whole thing, but this is far more comfortable to see. And both targets, each one of the target is actually flickering at a different frequency. So based on which target Chandresh is focusing on, it will be able to predict the target. So this is far more comfortable, and it also means less cognitive load. He doesn't have to imagine any movement. He just has to focus on a certain target, and the system should be able to predict the target he's focusing. So this again can be used to control the same digital avatar, the right and left hand, but instead of imagining a movement, you just watch a target. That's it. Okay. Okay, I can take more questions now.
Yeah. Thank you, Dr. Kishor. Yes, this is to all the people who have joined. Please unmute yourself, and if you have any questions, please ask. You can
I
also
have the
post
chat open as well, so
your
yeah,
questions on
if
the
you're
chat.
comfortable just asking in chat, that's fine too.
I have a question. So how does the model identify various noises in the environment? For example, the bright lights and all the other things, that can also cause these potential variabilities in the EEG.
That that is the constant pain of my existence, filtering out all the different noise and artifacts from EEG and making the model do it. So, I mean, today's demonstration, we are in a well-lit room and all these other disturbances. But usually when we do these kind of things, we keep them in a very noise-free environment so that you don't get all these additional artifacts. But in real time, we also have all these filters and other uh, independent component analysis algorithms built into it so that at some level you are able to filter it out and get what you need. But then again, it's in real time, so it doesn't really worry about the past or the future. It just keeps going at it, and eventually you get it right. That's why you see the small flicker that it's trying to figure out what they're doing, and then, like I said, it's not perfect, but to me at least, the aspect that you're controlling something just with your brain is really interesting.
Any questions from the audience?
Yeah, one question, just curious, who is your competition? Who are the other centers in India and abroad working that you would say these are the best of the best?
Uh, I wouldn't say competitor. I'm
No,
fortunate
but
enough to say they are. No, I'm fortunate
other
enough to
colleagues
say
at
they are
other
a
universities.
collaborator.
Yeah.
The Graz University, TU Graz University in Austria, they are one of the leading experts when it comes to brain-computer interface. This whole aspect of ERD, ERS, that came from one of the professors from TU Graz, Professor Frutscheller. And the imagining left and right movement and mapping that to motor imagery, it's actually called Graz BCI simulator. So they are a huge team, and I'm very thankful and happy that I'm actually collaborating with one of the major professors over there, Dr. Moritz. And he's the one who introduced me to SSVP, the Gabor patches. So we'll be collaborating with him, and we'll be collecting data in stroke patients here. And yeah, so they are really good, and I mean, for decades now, they've been the leading team when it comes to brain-computer interface. Of course, there are other teams in the US as well. There is a team in Cleveland Clinic who especially do amazing job in epilepsy detection and brain-computer interface using motor imagery. But yeah, if I would have to say, I would say TU Graz in Austria.
And Srinath, if you don't mind, can I have a couple more questions for the professor?
Absolutely.
So when you work with, let's say, stroke victims or people who have epilepsy and so on, again, confining it to India alone, given the India, the life expectancy is increasing, which is a good thing. But along with that, given the incidence of blood pressure, incidence of diabetes, the increased incidence of I would say obesity, metabolic syndrome, and so on, the chance of getting strokes is going to go up or is going up.
It is.
Right? So the work that you're doing is getting to be more important. What kind of support do you see or collaboration within the Indian establishment, let's say DST or the Department of Science and Technology or whoever the right one is, ANRF or whatever that is? Do you see increased interest in the Indian context alone? Because India is 1.4, 1.5 billion people, right? Most people don't understand how massive that is, right? The city of Mumbai has got the population of the country of Iraq, just as to give an example, right?
Yeah.
So just what do you think?
Well, I've been fortunate enough to have a grant from DST before. And right now I have a grant from ICMR. That's a
So
Indian
again, you might want to expand the acronym. I know what you're talking about, but many in the audience
So
from
DST is
Binghamton.
the Department of Science and Technology that has been renamed as ANRF, the Anusandhan Science Foundation. Am I right?
National Research Foundation, ANRF.
National Research. So that's our equivalent of
NSF.
Yeah, NSF. And then you have ICMR, the Indian Council for Medical Research. And so I've got grants from both these organizations, and both of them are on rehabilitation using stroke rehabilitation using motor imagery and brain computer interface. So I would say that the interest is definitely there, and ICMR these days, one of the fields is related to stroke health. So I actually applied under that subcategory, and I was able to get this grant.
I have other questions, but I'll ask you on November 6th.
Sure thing.
No, it's a very interesting topic.
I'll be happy if you can visit the lab. We are in the Pearl building.
If I will try my best. I think I've been there before, but I will, of course, I love to do that. And I know you guys are going to usually there in the evenings also. November 5th, I'll be there in the evening. There's a Wednesday.
Absolutely.
Srinath, any other questions, Srinath?
Any questions from the audience? Yes, Dr. Krishna, since you also mentioned about the human factors elements too, I think, we also have a few faculties here that works on the human factors side. Potentially, we can find some collaborative interest like Dr. Stephanie and Dr. Amanda
Absolutely.
Chad.
Yeah.
So we can definitely, connect offline to see if there are any common interests there.
That's the thing with researchers like us, right? Every opportunity that we get, every talk is for finding potential collaborators,
Yes.
learning from them, and expanding our research. So I'll be happy to. You have my email ID and contact information, so if you can just send it over, I'd be happy to. Yeah, I'll be happy to answer any questions, or I'll be happy to respond to any collaboration requests through email. So,
Okay. Yeah. And I think one of our future speakers from, we have identified one speaker like Dr. Inge Zhou. So he'll be also talking about a little bit of the biomedical applications area, especially I think 3D printed sacrificial molds and like some tissue engineering applications. Potentially I think we can also have some ideas that we can share at that point as well.
absolutely.
Any other questions?
Srinath, when Dr. Geeta is here next week, actually next Friday, we might want to talk about increased participation in research, just to pick up on the point that was just made between faculty on both sides. Yeah. And between students on both sides also, right? For example, I saw Asar on the list. She's doing an excellent job on cardiology, and I'm sure there are others also. So things like that we can explore to see how we can have more student participation.
Yes. Yes, Doctor. So before we conclude, I also wanted to talk about the two of our upcoming speakers from Binghamton. So the next one that we will have is Dr. Inge Zhou. So his presentation will elaborate to novel manufacturing approaches to fabricate vascularized tissue scaffolds using core shell, electrospinning, and 3D printing sacrificial molds. For hydrogel for tissue engineering application, I see there is a lot of potential collaborations with the Shine on this. And we also have an upcoming speaker, Dr. Safa Al-Kefi, who will talk about using medical informatics, AI, and virtual reality to enhance healthcare delivery and educational outcomes. So she will also talk about a little bit on AI-assisted diagnostic tool, VR-based patient education and preparedness program. So we will send the information about those dates and the link to that pretty soon. So I just wanted to announce that before we conclude. And at this point
Just add to it, Dr. Srinath, I mean, we have a huge, a lot of our faculties per se, in terms of tissue engineering, 3D bioprinting, and areas like that, and advanced manufacturing, biomanufacturing itself, they'll be really happy to kind of, interact and collaborate along those aspects. And AI and ML, of course, we do have some level of expertise, but we are now wanting to expand into this particular area, and for obvious reasons, because we see that future and how things go along. So thank you for really mentioning these two. We would also pass on the information so that we could have more faculties and student interact from this side also, and it could benefit the most then. Yeah.
Thank you, Dr. Yagendra. First of all, I would like to thank Dr. Kishor today for presenting this amazing research and showing us the demo. So we are really delighted to have you here, Dr. Kishor, and hopefully we can have some more collaborative efforts that we can do from the SSIE and Shine. And thank you, Dr. Hari, for initiating this particular collaborative with Shine, and we are very happy to have this collaboration. We want to see this succeed. And thank you, Dr. Yagendra, for arranging all these things too.
Sure. I would also be sharing our list from our side so that, in the meantime, I've not yet finalized, but I'll definitely be sharing at the earliest. So thank you very much once again. Thank you, Dr. Srihari. Thank you, Dr. Srinath, and thank you everyone for really this collaborative efforts.
Yeah, thank you for all the participation. Thank you.
Thank you.
Thank you.
Bye.
Thank you.